There's a lot of information in a lot of different resources. Did you know there's a National Pressure Ulcer Day?
No.
Yes.
There's an actual Wound Awareness Month, which is in June. So you'll see all kinds of posters and stuff out of my door because I'm one of those crazy people who are like, woo woo, it's awesome. Okay. So overall, with this lecture, unlike some of the other etiologies, there's a ton of prevention that we are going to talk about and what we're going to do for that. But then it comes down to, for some of the other pathologies, there's a very scripted intervention, treatment, etc. Oh, I have something up for you before I forget about it. And that is, I have to pull it up real quick. I will keep talking as I do this.
Wow.
So some of the statistics that are involved in the U.S. is pressure ulcers normally cost us $3.6 billion a year in medical expenses. It's a huge, huge financial incentive. So they do now have, there is a national prevalence and incidence basically campaign, and so they have statistics and other things available and different recommendations via books. There is a regulating body called the NPUAP for the states, United States, which is the National Pressure Ulcer Advisory Panel. There is also a European Pressure Ulcer Advisory Panel, and they're called UAP, or you'll see NPUAP here a lot. So in a lot of the slides, you'll see those abbreviations. So if you've never seen them, look up. This is an occipital. That's an occipital pressure injury from someone who was in a vegetative state. And now I'm Turner. So she lay like this for a very long time. And so this beautiful thing is her skull. That's exposed. Okay. If you can't see the pictures good enough, kill the lights. This is a sacral. Okay. Here's my gluteal fold. So this is a coccygeal sacral and left medial gluteal fold. This is another one, which is really true sacral, but I can't tell exactly because the whole thing is obscured by slough. And that is a pressure injury on the heel from, again, not being able to deblate the heels and constantly having our legs in external or internal rotation. This is what an infected ulceration looks like. Can anyone guess what this is? You got it. Her spine's exposed. Yep. You ever want to make me nervous? Expose the spine or expose the pericardium? It's the only two things that still make me nervous for the day, right? Oh boy. The other stuff I'm okay with. But these can get really bad with infections. And that one is all pixelated, which I'm so sad about. That is the peroneal tendon. It was all dead. It was a fantastic picture. Check those out. Okay, so depending on where you look for the sources, I gave you 3 different definitions. Okay, what do you care about for the test? This. This is the standard of care. Okay. This is the National Pressure Ulcer Advisory Panel. All of this stuff is online. I took a lot of pictures. I updated this pretty extensively. Okay, so we have pressure injury. So the definition of it is a localized damage to the skin and underlying soft tissue, usually over a bony prominence and or related to a medical or other device. If it's not on a bony prominence, it's not a pressure injury. Don't call it that. unless it's related to a medical device, which we'll show you. Okay. The injury can involve intact skin. It can be just intact skin that's discolored. It can be an ulcer. It can be a blister. It can be missing enormous amounts of tissue. It can present lots of different ways. The injury occurs because of intense pressure, prolonged pressure, or pressure in combination with shearing. The tolerance of soft tissue for pressure and shearing may also be affected by microclimate, nutrition, perfusion, comorbidities, conditions of the soft tissue. Okay, you will see links like this. Okay, and you will see where all of these things came from. So if you click the link, they're all working links in the presentation. Wait for it. Nothing. All right, I'm impatient, so. Document and where it was found online. Because these have a tendency to adjust and update. And so when you see a pressure injury, the website you should always go to is npuap.org. Always. They have the most recent information, the most recent clinical practice guidelines, and everything else associated with that. I wanted to bring this up because underneath this folder, I posted a ton of material. Okay. And so almost everything that is linked in the PowerPoint is all here for you. You don't have to go searching for the document. Okay. So these are all really good resources. These also give you some other resources related to all the different topics that you'll see. This is the huge one that if you think your case is an NPUAP clinical practice guideline book, this book is approximately 86 pages. And then they have one for spinal cords as well. Okay, so we'll actually bring that up. We're going to read that one up so you can sit there. Okay, so quickly, pathophysiology. All right, so it can occur because of immobility, moisture, friction, or shearing. And so these are supposed to correspond. Get it? Okay. Moisture, right? Moisture can be from a variety of sources. You can have incontinence. You can have lots of sweat. You can have lots of drainage. You can have lots of, usually those are the three major players. Fluid drainage, continence is the huge one. Okay. And then perspiration. If you have a lot of moisture, then you're much more vulnerable. The skin is much more vulnerable to shearing and friction forces. And if you shear macerated or wet skin, it tears typically. Okay? Friction is when you have right force of gravity and you slide across. So friction is applied between two surfaces, right? I'm creating friction in my hands when I do that. So just imagine the body pushing against sometimes you get, if you're a marathon runner, you ever see the friction burns they get underneath their clothes, especially the women and their breasts, because of all the rubbing and friction. You get major injuries sometimes underneath sportswear, which is why there's so much design into the sportswear now to protect friction or shearing injuries. Okay? Something that's really important for you to remember always, and for the boards, because this is always somewhere on the boards. Friction alone only affects the epidermis for damage. Okay? So if you want more explanation, friction also causes damage to the capillary. That can then lead to tissue anoxia, which then leads to necrosis, which then can lead to undermining. That's why you usually see in deeper wounds, you usually see some level of undermining. If you see undermining, it's linked to friction. Could be linked to friction. Okay. Shearing is what happens when you elevate the head of the bed for the patient. Oh, let me raise up your bed and sit you up. And as your skin is moving down, the sheets are pulling this way and shearing across your skin. So it's not the same as friction, with the constant velocity of friction. Okay? But it's a force applied parallel to the tissue. Okay? This is a really good clarification of how shearing and friction are different, but I don't have time to go into this PowerPoint. This was put out by the NPUAP, so if you want to go access that source to understand it more, you're welcome to do it. Okay. So what happens is, let me ask you this. If you know that it occurs over a bony prominence, it is not pressure down, it is pressure up. Think about that. The actual damage starts, the pressure comes externally, but the damage starts inside and works its way up. Okay? Because the most damage is where the compression is. So prolonged pressure applied to a body part or bony prominence compresses everything, all the tissue, whatever's there. The fascia, the fat, the muscle, all of it. Okay? The pressure has to be enough to close the capillaries. If the pressure closes the capillaries, now I obstructed my blood flow. That then leads to tissue ischemia. Then I obstruct the lymphatic channels. Then I obstruct the venous channels. Okay? So then I have all this metabolic waste hanging out. They can't get anywhere. It's just there. Okay? So then, because I can't get rid of it, I start to swell. Because I've got to get this stuff away because it's toxic. So then I increase my inflammation, I increase my edema, and then the ischemia causes fibrinolysis, so I get fibrin deposits down, and then I throw microthrombi, and I further clot the vessels, and then I have permanent ischemia that leads to tissue necrosis. So in other words, this is a much simpler explanation. Okay? Every pressure injury starts with here. So if I don't get rid of this, I don't fix it. Period. If I don't get rid of the pressure, so as soon as I look at pressure injuries, I always say, okay, here's what it is right now, and the second part is how we're going to get rid of it. Not the wound, how are we going to get rid of the pressure? What do we have to do educationally, positionally, bed-wise, anything? What are the other things I have to do? But if you understand that the pressure comes externally, but the damage is from the bone pushing up onto the other tissues, etc. And it's not physically the bone, but you understand the pressure pushes down, and then it starts down here. So when you first look at a pressure injury, and you'll see some of them, you may not know how bad it is until a couple of days from now. Because it's still evolving. You will not see it on the surface of their skin yet. Okay? So these, I do want you to watch because it's a great video.
We now know that the primary cause of tissue damage is direct deformation, direct cell tissue deformation, as opposed to just ischemia. So if it's just pure ischemia, if the muscle is not deformed and it's just the blood flow, tissues such as muscle tissues, such as skeletal muscle, can probably survive several hours until damage starts to onset. As opposed to that, we know from our animal studies that if you apply high enough loading, you would cause cell death, you would cause tissue damage after minutes to hours. And so when you put these puzzles of the picture together, you see that it is very, very likely that deformation-induced damage, so direct deformation-induced damage, comes before ischemic damage. Based on all the ecological work that we have done, that the most important thing would be to minimize internal tissue deformations and to avoid conditions where you have high localized tissue deformations. Ischemia is not the whole story. Actually, ischemia is just a part, maybe a smaller part of the story with respect to the direct effect of tissue deformations. We basically know that deformation damage comes first, ischemic damage comes on top of that, and damage can actually happen very quickly. As I was saying, minutes to hours.
So why is that such a big deal for me to show you?
Full part of the story.
Because when I first learned, we were taught it was always ischemia. It was ischemia. And so if you used all these different devices to increase the blood flow, you'd be fine. And they found out it didn't work. And so they've been doing a lot of research. She's one of the researchers that has been leading within the pressure injury world. And they've done a lot of studies, and they can now permanently defend it's not ischemia alone, it's the cell tissue death. So the pressure deformation causes cell tissue death. It can happen. I've got a chart. You'll see how fast it can happen. Okay. If you really want to have fun, and what I wish we had was I wish that they have some really cool surface. I don't know if you've ever seen them. They're surface machines where you sit down and it'll tell you in thermal. It's almost like CT. And it'll show you as I shift my weight where my pressure is. And it'll show you the bone. It'll light up in red, yellow, orange, green. And it'll show you here. And what we should do sometime, if you ever get the technology, I would love to have it to show you, because how many times you shift in your seat unconsciously, I believe is every 30 seconds. Your body's constantly changing its posture, and it does it while you sleep too, but not at the same frequency. So intrinsically, we are ready to move all the time. And if we prohibit patients from doing that, we get a lot of bad things to happen. But a lot of the other thing about pressure injuries, and a really big take-home message for you to understand, is that we can do everything right, and they still may get worse. And they still may get pressure injuries, because sometimes it's out of our hands. And so one of the hardest litigations I was ever involved in was a pressure injury case. And I was on the stand, and I had to defend why I wasn't at fault for this patient who died. And what did I do with my standard of care? And so they tore apart the clinical practice guidelines and everything else, and I had every single thing in there. Luckily, I was one piece of the puzzle. It was a very huge trial that went on. Never want to do that again. And I got called to be an expert witness, and I said, nope. I want to get as far away from courtrooms as possible. I never want to do that again. Because it was the way people can twist information, I can't handle it all very much. So, the reason why that's so important is because how much pressure is required. If you talk to an old school clinician like me, we're going to tell you 32 millimeters mercury of pressure. It's not right. This is the old thought of school. And there's a video telling you why it doesn't work right there if you want to watch the old school stuff. But if you hear that, that's okay. We do know that critical pressure, it depends on who the person is, how much body tissue they have, and what position are they in, and what other things are affecting. It's individual. There's no magic number. There's no magic pressure number. Okay? It can depend on the intensity of the pressure, the duration of the pressure, and the tissue tolerance. So we have an indirect line here. Okay? So we know that if we have a high amount of pressure in a short amount of time, it's going to do a lot of damage, versus a low amount of pressure over a long time. It'll take longer for that damage to occur. Okay, so the higher the amount of sustained pressure, the shorter the time frame you can get tissue and cell death. That's the take home. And then there's two different kind of pictures showing you the same thing. Here's how long it takes. 2 to 6 hours of unrelieved pressure, you can get an injury. Within 30 minutes, you can get an injury. And then 2 to 6 hours of prolonged can go. More than 6 hours of unrelieved pressure is when you get necrosis. Tissue ischemia, these terms are huge. Tissue hyperemia means it is what? What does it mean? Blanchable erythema redness. So if I come up to a patient, let's say I've got Jake here, and I'm looking at his elbow and I'm saying, okay, let's see. If I take my finger and I push on this area and I relieve it, you see how you turn back? You can't. That example. Push here. No, see, that didn't. Okay, let me show. Stand up. Let me show everybody on you, and then we'll have someone show you. Okay. So here's his elbow. If I take his elbow and I push and I relieve, can you see the change? Push and relieve. You see how it returns to his normal color? So so that's fine. He's got normal return. His capillaries, when I push on his capillaries, and then I release them, they're refilling. Okay? Now, I need someone else says, did you see it that way? Yeah. So if I push on it and it doesn't go away and I still see my white thumbprint, that's unblanchable erythema. So you just saw on him, this is blanchable. Okay? If I push and it doesn't come back, it's unblanchable. That means I've got tissue hyperemia right now. It's the very beginning of this vicious cycle. Get the pressure off of it, is what it means. Are you with me? Okay? So, right now, no. I said that wrong. Blanchable erythema. Okay? So if this area was red, okay, and I pushed it and it comes back, that means I've got tissue hyperemia. Okay? Alone on my skin right now, if I have normal skin and no erythema, I'm just a normal person, right? I don't have anything going on. If I push on the red and it doesn't come back, that's unblanchable erythema. And that's important because it's going to come to the definitions of staging in just a few minutes. So blanchable erythema is when you see an area that could be red, it could be purple, it could be dark brown, it could be a lot of different colors based on what their baseline pigmentation is. If I see an area of either hyperpigmentation or an area of redness, I'll show you some pictures, and I see that, and then I push on it and it goes away. Right, I push here, it comes back, that's blanchable erythema. Okay, that tells me right now this area that's red, or whatever color it is, has tissue hyperemia, which is the very first step. Okay, if I don't get rid of the tissue hyperemia, it will progress to the tissue necrosis, to the tissue ischemia. If I don't get rid of the tissue ischemia, it will progress to necrosis. And I have less than 6 hours to fix it. Okay? So that's the take home. Uh-oh. Okay, risk factors, there's lots of them. Lots of things that can happen. Pressure, time, friction, shear, and moisture. We talked about those. Impaired mobility, malnutrition, impaired sensation, age, etc. So in order to assess risk factors on admittance to a skilled nursing facility or on admittance to an inpatient hospital or a subacute rehab, wherever you're going to stay overnight, there's usually some risk assessment tool that's used. Who is it used by? Could be the PT. Usually it's done by the floor nurses. Or there is a wound care nurse in the facility. Okay. Every facility has their own protocols for these. Protocols. Okay. So there's risk factors that are available. The risk factors are these. Okay, well, I listed out all the risk factors here. Hold on. All right, I jumped ahead. Let me go back a minute. Okay. Other risk factors besides these include mobility, malnutrition, sensation, age. If you've had prior, PI means pressure injury, PU means pressure ulcer. You'll hear me interchangeably say, even though it should be pressure injury, I'm working on it. Okay. Any of these? This is huge, subclinical dehydration. If your patients are dehydrated, you need to be documenting it. If they have malnutrition, you need to be documenting it as a risk factor. Okay? If they have psychosocial issues, if they have Alzheimer's, Parkinson's, or RA, there's literature that states they're twice as likely to get it despite everything else, just because they have those diagnoses. If they have any of hemodynamic factors that are out of balance, so you can imagine almost everybody in the ICU, right? A lot of floors in the hospital. If they have an acute medical status or critical illness, those are all risk factors. Okay? And then the site of pressure application. This one's big. If you have fat pads or subcutaneous tissue, a lot of it in an area, it will distribute the pressure, so areas of fat are much less likelier to get one versus unpadded areas. Okay? Yes?
You said document risk factors. Is that even if the person does not currently have a pressure injury, or is that only if they have it?
Well, if I'm talking about wound healing or therapy healing, and what is going to play into a role for prognosis, it'll say barriers to therapy. That's where I put all this stuff. Either on my normal evals, like let's say they just had a stroke, but let's say that they have an unstable, there's other things playing in, or if they have, be it a regular PT patient or a wound patient. I'm always looking at everything and saying, how likely are they going to reach? So it's not just whether or not even they're going to comply, it's what's their medical status. But I'm on the acute end of things, right? So you would adjust that then according to whatever facility you're in. So here's the risk factors you can use, the risk factor tools. Oh. All right. Here they are. Here's the names. Braden Q, that's for little people. Braden and for adults. So these are the most two common. Then you've got Norton and Gosnell. What I did on here was I wrote, here is each scale. I put them in. So you have a screen here that tells you a summary, and then they tell you one by one how do you use these. You want to know the Braden scales and the Braden Q scales. And basically, the lower the number, the higher the risk on both of those. The lower the number, the higher the risk. Now, on the boards, if they want to be really fun, they will ask you, which of these, they'll give you like 4 different scales and say, here's the score, what does it mean? And which one applies to the case. So I gave you this stuff for reference, in case you see. You'll run into Braden and Braden Q frequently. The other ones, I don't know how much you'll run into them. But I'd rather have you know the information than not. These are all for assessing risk. Risk of opening. Okay? So what do we do for prevention? Here's your pressure injury prevention points. They have all kinds of pressure injury tools, brochures, all kinds of stuff you can get from NPUAP. Usually, a wound care team is doing this stuff throughout the facilities. Or there's a wound care nurse or someone. So what do? Okay? You make sure that you're assessing fragile skin. Well, what are they sitting on? You're looking head to toe. It's not good enough just to look at their front side. You have to look at their sides and their back side too. You have to do it's a head to toe skin check is what they call it in nursing. Okay? And then you need to repeat the risk assessment as they go through the introductory. These are usually done on the inpatient side with these risk scales. However, if a patient comes to me in outpatient land and they have a pressure injury, you better bet I'm doing this independently. Because I want to see what is the risk factor of getting it with the physicians and stuff that they're in right now. So it's not limited just to the hospital side. Okay? Okay. You're having so much fun. Okay. Other prevention strategies. So, manage the medical factors. Can you manage the comorbidities? No, but medically we can, right? Manage the continence. Protect the skin with moisture barrier stuff. Don't shear their skin. Lift, don't drag. Lift, don't drag. Don't drag them up. Just don't drag the skin. When you're doing transfers, don't drag them across the slide board. Lift and help. They have really cool assistive, what's the thing that we use at Christ? The big lift. No, the one that lays in the bed. In the ICU beds. Have you been in the ICU? Yeah. There's a long sheet with handles. What? I can't think of what it's called. Anyways, it's a long sheet, it fits in the bed, it goes all the way across, and they've got handles. And it's designed for 5 men to lift and move the patient. So you use tools like that underneath the stuff to help you move, so you're not shearing or dragging. Okay? All right, here's other tips for skincare, for nutrition. In the interest of time, I'm going to let all of you read those because I think they're pretty self-explanatory. But then they also came out with best medical practice to prevent pressure injuries. And there's something called medical device-related pressure injuries. So, I have a trach. I have a ventilator. Okay? I have a ventilator in my throat. I have a G tube in my nose. I have a subclavian line right here. And I'm unconscious, and I have a ventilator breathing for me. Leave these tubes in place for a week and a half. And underneath them, you will see tissue damage. And that's a medical device-related pressure injury. We don't want those. So they came out with all of these lists that are posters you can post around. You can get the poster by going there and clicking it. I just took pictures and put them in. And this is underneath all of these, they have all the pictures of medical devices, of what they actually look like. Okay? And so you can use those. A lot of them is educate, offload, monitor comorbidities. So they have best prevention acts for medical devices in adults, in pediatrics, in critical care, in long-term care, okay, all kinds. And here's the things you're going to educate on. We don't use diapers as a substitute for skincare. Many facilities have banned them. They don't allow adult diapers anymore. Kids, yes, you're going to put a diaper on. Okay, but not necessarily if they're sick. They may not have them on. They may just have catheters or other things in place because they're just too sick and they won't take the chance. So ask questions that clarify points if you see something in the clinic that you don't understand. Okay? And education is the huge thing. So turning and repositioning is the other big thing. You need a turning and repositioning regimen, which means that you have to keep the linens wrinkle-free. You need to make sure that they are at a 30-degree instead of all the way on their side, which then pushes pressure on the greater trochanter. You do 30-degree wedge turns. Okay? Then you go back, then you go wedge turn this way, then you go back. Sometimes we have beds that do it for you. Just know the bed's not a substitute. And if you roll a person who's unconscious in a bed that turns them, their pressure still may not be offloaded. Yes?
the beds not substitute for what?
Positioning. So some beds are high tech and will do all the positioning and 30 degrees turns for you. They will also flip the patient all the way around. So they can be supine and off their backside. Okay.
So how is it not?
Well, it's not a substitute for good. If someone is unconscious, say for example, and they are lying down like this, and then I turn them on their side, they're still now here on a 30-degree tilt. So I may have to still reposition them in the 30-degree tilt bed to get the pressure to where I need it to be. That's what I mean. Better? Okay. Use pillows or foam pads. Keep the head of the bed the lowest setting possible. Okay. Lowest setting possible to minimize shearing. The worst thing you can do is have the head of the bed 30 to 90, 30 to 90. Where's everybody's hospital beds? 30 to 90. If they have a pressure injury, it needs to be usually less than 30 degrees, typically. However, if they've got aspiration precautions or if they have an ICP, they can't go less than 30 degrees. And then what I would do in that case, I would document it. And say, you can't follow that because there's precautions because of their medical status. Okay. Here's anything in green like this is directly from there, and then that's the resource where this is from. Here's all their repositioning and mobilization. To give you an idea of how big this topic is for pressure injuries, you can go to a 4-day conference for pressure injuries only. 4 days. Like CSM, but just pressure injuries. So this is just the bare knowledge that I'm sharing. You want to know more? I'm happy to talk about it. But I'm not doing that to you. Okay. All the prevention strategies, like all these individual ones, you don't need to know this for the exam. You need to know the general rule of thumb. What am I going to do? I'm going to turn them, reposition them, I'm going to educate them. What am I going to educate them in? I'm not after all these other things, but when you encounter it in the clinic, you need these references. So if you don't have the references, that's not good. All right. Now, the other thing that happened when I graduated was we've always had this Q2 hours, you have to change everybody. Every hour, every 2 hours, you go around down the hall, you turn them off. And then 2 hours later, you come back and turn them on. Do you know that there's no literature stating that that's right? 0. 50 years. I went back in a 50-year search. There is still no literature that states Q2 hours is there. It is not supported. Some facility, most likely, that was their nursing shift. And that's where it came from. Okay? So their turning regimen should be based on the patient, on what the patient needs. Okay? So what I did now in the next couple of slides is for you to understand what positions are good, what positions are bad. So what you want to know of what positions cause pressure injuries and what positions and how should you reposition people. So supine, here's the most common pressure injuries that you'll see. Okay, here's how to fix it. I gave you every position here. Here's the problem. Here's the problem. Here's how to fix it. And I think the positions help you to see it better when you break it down like this. Sideline, here's the problems. Okay? And then wheelchair. I don't know how extensively you remember this stuff, but I put it in every single slide and book I had for you. All about envelopment. Remember cushions? Have you learned about cushions? To this extent? You don't learn about wheelchair positions? Like offloading positions? Okay, well then I won't find her. This one, so cushions can be created. Okay. Typically you have, these are your typical dimensions for wheelchairs, okay? The red are the areas where you see pressure injuries usually occur. So These are the typical, here's the problem, and here's what you can, this is how it affects the posture, that's what these slides show you. Okay? And different positionings of different things. Here's all of the positions together. Where did it go? That's all heel projectors, hold on. There it is, okay. So my goal for, if I want to introduce cushions to a chair, I want to target or load, I want to redistribute the pressure in an even fashion so no bone incontinence gets too much of it. Does that make sense to you? Okay. So I want to also make sure that I'm managing the temperature and I'm managing the moisture, because temperature and moisture are also risk factors for pressure injuries. So I can have a great cushion, but if they're sweating profusely and sitting in drainage, it doesn't do me any good. Okay? So one of the ways, there's two ways I can fix the cushion. One is an envelopment, and two is redistribution or offloading. Okay? Envelopment means the ability of a surface to deform around and adhere. You know the foam mattresses at night for regular beds? You see all kinds of ads. Oh, you see how the person moves and how it moves around them. That's an envelopment. Okay? The cushion deflects and deforms to the immersed area. You should have 4 centimeters of immersion necessary to encompass the buttocks. Therefore, you have about 5 inches or 5 centimeter cushions. Why do I care about this? This is an analogy for you. There's a lot of technology that goes into it. They measure out all of this stuff before they make the cushions. So they know exactly how many inches or centimeters of things that are needed on their end. It's not something we're calculating as PTs. Okay. There's also cushions with cutouts to offload different areas around different things. Which one do you need? Depends on who you are. Okay. The cutouts will redirect forces away from bone incontinences. What you don't use is the donut cushion. You know what I'm talking about? The little donut whoopee cushion that you sit down and you put right here, and a bunch of old people have them in nursing homes, and they sit on it, because it increases the pressure on their sacrum and coccyx exponentially. And almost all of them will end up with a pressure injury. So you're not supposed to sit on it, even though I know that that's what their mother told them in 1920. It doesn't work. Okay? So these are some different designs to show you how they can be adjusted to people. You can make these cushions with more lateral thigh support, with more lateral pelvic support, medial thigh support. They can change all of it for each patient. It is awesome technology. Really awesome technology. Okay. Now, besides wheelchair cushions, there's other things you can do. And the big problem is the heels. How are we going to offload the heels and the feet so you don't get a heel ulcer? Okay? Well, you can use protectors or boots. You can use mattresses or overlays. You can use all kinds of different things. These are some examples of foam boots with suspended heels. I have never yet met a person who keeps those on and wears them right. I hate them. I understand they're necessary, but most of the people, we put it on correctly, and then they pull their heel out of there, or they start to rub their heel inside the foam boot, and it's obsolete. These are a Prefo. Have you learned about Prefos? Prefabricated ankle foot orthoses. So it's a rigid metal band, holds the foot into 90-90, okay, like this. Has a bar right here that switches out, so when you lay, instead of your legs going like this, it holds them like this. And the bottom right here has a heel blowout. So this actually, there's just the heel end, and the band of metal goes underneath it. So it's a really cool way to offload. The problem with these is if you don't fit them right, they break down at the ankle because no one put it on right. So there's pros and cons behind all of these things. These are some slides that tell you step by step by step what we want, and what we don't want. Okay, different positions. I would be cautious when you're raising it up. This is ideal, but you don't want to block the popliteal space. Okay? You also have to think before you do. If they just had orthopedic surgery, can their leg be in that position? Right? So you have to think about medically. So not everyone fits the best. And then they have all kinds of different technologies in beds. Okay? When you go to these big pressure injury conventions, they have basically soldier field filled with every single type of mobility device that's out there. I try to summarize it like in 3 slides. Because I'm like, okay, where do we start with this for you guys? Okay, so we can change the technology to allow for constant offloading depending on severity of pressure injury. That's the basics. You have 2 types, pressure reducing and pressure relieving. Okay? Pressure reducing means it's a cushion or a foam pad I'm going to put on a chair on a healthy person. It's going to reduce some of the pressure so I don't get uncomfortable. Okay? Dynamic support surfaces is anything plugged in that's going to move and conform. Okay? So typically static support devices are for non-moving devices. Okay? NPUAP suggests using these or these based off of their clinical practice guidelines. What I didn't realize is that some of my slides from the NPUAP may be incorrect, and I'm going to make a big disclaimer right now. This, I don't know if this is still valid. And some of the tips about modalities, because they upgraded the clinical practice guidelines, and I think this was from the prior book. So these 2 things down here in blue, I would say go see the clinical practice guideline book to verify. Okay. And then if anyone does go verify it and you find out what's wrong, you please email. Let me know, tell me, so I can change it. Okay. Here's examples of static support devices, dynamic support devices. Okay. The biggest thing that's confusing for people is you'll run into Clinitron beds, which are basically air fluidized, circulating. So let me just show you. Here's all the different names of the things that you have to know when you're operating these machineries. So this would be, this is an airflow, a low airflow loss. This is what the inside of the mattress looks like. It's multi-chamber, and you can control all the different chambers to be at different settings for the patient to offload them continuously. Okay? There's really, one of the things too is if they're on any of these things that are here, you need to know, you need to be oriented to the bed, because it's not a typical hospital bed, and there's settings you need to hit to get them up out of the bed. Otherwise, this is really hard to get out of. There's a setting you switch it to, and every place is different with what device you have. So you have to get oriented to the mechanics of the bed. Okay? That's what it looks like inside. Here's other ones. This is an alternating pressure low air loss. The definitions are all underneath there. These you can actually sweat and pee through, and it will filter it. It won't allow anything to hit to the skin. Okay? And this is the famous Clinitron bed that everybody needs. Okay. Patients hate them, staff hate them. It's really awesome because all the moisture, you can spill a bottle of water and the whole thing will go into the silicone beads underneath the bed. It feels like you're floating in space. It's a really cool bed. You plug it in, there's a head elevator. The head elevator is about only this much of movement. The rest of it's all fluid. So basically from your pelvic crest down, well, what is it? It's basically I think it's T11 or 12 down, you're offloaded. Okay, so these are what you'll typically see for flaps. If you are on flaps or grafts, you'll see these. These beds push out a ton of hot air, and almost all of them are on contact isolation. So I'm telling you now, if you have these, I have extra scrubs at work for a reason, because when I'm done working with it, I usually sweat through my scrubs because of how hot the room is. So just FYI, you're going to work with these for about a 30-minute session. You're going to be really hot. And you can't do anything about it because the patient needs it. Okay, so the big one that we're going to talk about is this part. How do we assess the pressure injuries? The biggest thing you have to understand is the staging. We use a staging system specific to pressure injuries to help determine and quantify the extent. The standard practice of care is when you see a pressure injury, you should be staging these. Should be, okay? So this is my general flow. This is not in a book. This is just at least to kind of help you figure out where do you go, what do you do with these. Pretty much follows along what we've done so far in the class, except the step of identify what stage it is, okay? So, I can't tell you how important the anatomical terms are. We've already talked a lot about that. Make sure the coccyx is the coccyx. Here's some examples of missed things. A lot of people will say, oh, it's a hip wound, and this is actually what I walk into. It's not a hip wound, okay? That's a gluteal fold. Okay? This is an ischial tuberosity. Okay? This is a sacrum. Down here would be a coccyx. This would be a thoracic spine or a lumbar spine, right? So you just make sure where you are, wherever the wound is, palpate and feel what structure are you on. That's how you state these correctly. You don't want to be wrong. Four pictures. Here we go. Stage 1. This is what happens to the skin. This is what it looks like. This is the erythema I was talking about. So the first things I would go to is I would walk up to this and say, okay, where is it anatomically? Okay, and then I would push and see, does it come back? So I push down, it deflects to white, I let go, it comes back to red, it's reactive hyperemia. I push down, it changes to white, I let go, it stays white. Now we have a problem. Now that classifies as a stage 1 pressure injury. Stage 1, non-blanchable erythema is what the name is. Okay. It may appear very differently if you have a darker pigmentation. And they're very hard to pick up in darker pigmentations. Yes?
So the non-blanchable president won't be different, right?
Oh no, you will change the color from your pressure because you're still doing capillary compression. It will change the color. The problem is when I release it, the color doesn't come back, which means the capillaries are not so happy anymore. Okay. If you see maroon or purple, that does not fall into this. Maroon and purple hue relate to this. This is a deep tissue pressure injury, which is very different. Okay. You see the coloration? This is intact or non-intact skin with persistent non-blanchable deep maroon, red, purple discoloration or epidermal separation, revealing a dark wound bed or blood-filled blister. Okay. The injury results from intense and prolonged pressure and shearing forces at the bone-muscle interface. The wound may evolve rapidly to reveal the actual extent of the tissue injury, or it may resolve without tissue loss. If necrotic tissue, subcutaneous tissue, granulation tissue, fascia, muscle, or anything else is identified, this indicates a full thickness pressure injury. Okay, so when you're looking and if you see purple and intact skin, you would say this is a deep tissue pressure injury. If I'm looking and I see purple, but I also see all of these other anatomical structures, now it's staged as whatever else the other ones are that I'm going to go back to. Okay. So if I see purple, intact skin, deep tissue. If I see purple, blister, a little bit of epidermal splitting, still deep tissue. If I see red, stage 1. Notice it's a numeric numeric number, stage 1. The reason why this is significant is because in 2018, they changed this. It used to be Roman numerals, and then people were goofing it up. They've been goofing it up ever since they put Roman numerals out since 2006. So they finally have all just gone to regular numbers. Okay, so you may still see the Roman numerals in the charts, means the same thing. Stage 2 pressure injury means that I have now reached the epidermis and I'm into the dermal layer of the skin. Okay? I do not see adipose tissue. I do not see slough or eschar typically. The wound bed is viable peak, red, or moist, or it may also be an intact fluid-filled blister over a bony prominence. Either one is classified as a stage 2. Okay? Then for full thickness, now I'm reaching beyond the dermal layer. So each stage is going deeper and deeper, understanding? Stage 3, I'm into adipose tissue. I've got full thickness tissue loss, including adipose tissue. I typically will see granulation tissue here. I typically may see sulfur eschar here. Okay. I may see undermining or tunneling. I will not see undermining and tunneling in anything else except a stage 3 or stage 4 pressure injury. So if you see undermining or tunneling, it's stage 3 or stage 4. Okay? But I do not see fascia, muscle, tendon, ligament, cartilage, or bone. Okay. If I see a big area, but the whole thing is covered, it's over bony prominence, but the whole thing is covered with slough or eschar, that's you. It is now called an unstageable pressure injury because I can't see the bottom. This is fun, isn't it? Which is why we have slides with definitions, because you're all shaking your heads like, what? It's hard. You've got stage 1, 2, 3, 4, and then you have unstageable and deep tissue, and now you have a mucosal pressure injury as well. When I started, there were 4 stages. That was it. But they've gotten smarter and they've done a lot more research. Stage 4 means I'm down all the way to bone, muscle, fascia, the deepest. Both stage 3 and stage 4 are full thickness. Stage 2 is partial thickness. Unstageable means I know I have a gap of hole, but it's all covered by stuff and I can't see the bottom. And then we talk about deep tissue injuries. So what happens is I do an eval, I look at this, I stage it. Whatever you stage it at, it stays that number, that setting the entire time. It is always staged the same way. It does not progress from a stage 3 to a stage 2 to a stage 1. Once a stage 4, always a stage 4. Once a DTI, always a DTI. Once an unstageable pressure injury, always an unstageable pressure injury. The way to document it is a healing unstageable pressure injury, a healing stage 4 pressure injury. Does that make sense? You can't reverse stage. So that's what some of the other slides are about. Then the last thing you have is the mucosal membrane pressure injuries. These are when you get mucosal damage because of medical devices, very commonly in the esophagus, nasal areas, and if we didn't put these in the patients, they wouldn't work. So there is a risk associated with the lines. If you do see blisters and ulcerations within the mucosal lining, it usually requires all hands on deck, and it's usually not handled by PT. But you have to identify it and get it to the right practitioner. Okay? Here are some tips that they now have out for you for classifying pressure injuries. I summarize them here for you in terms of how do you do this, so you can read through those slides. Okay. And then here's also more information about medical device associated pressure injuries for you. And here are some pictures of those. This is the person's nose, and this is from a CPAP machine that sat on his face, right? This whole thing looks like this that sits on. So it sat right on his nose, so there's all the eschar. Okay, can you see the breakdown underneath the oxygen tubing? Okay, this is from sitting on a commode for too long. Okay, this is from an ET tube that was taped for too long. This is from an inappropriately dressed wound, and this is what happened to his patella. Okay. This is from a bad fitting brace. I've also seen a lot of cast injuries as well. Okay. And these slides are also important for you to know. This is how you tell, because some of the stuff on the butt is very hard to pick up on. There's a lot of stuff that could be other than a pressure injury if it's on the bottom. Okay. So you can have incontinence-associated dermatitis. I have people who rate this as pressure injuries routinely. It's not a pressure injury. It's not. There's no damage there. It's because of incontinence. And if you look closely at the skin's actually intact underneath that area. It's just raw. Okay? If you ever leave a diaper on a kid too long, you'll get the same thing. I don't suggest trying it on your child. It'll be very unhappy. Okay. You may also have abscesses that come up. The abscesses can occur anywhere in the body. So always look to see if it's on the bony prominence. Okay? You can have burns, you can have infections, skin tears, and inflammatory wounds. Okay? This is pyoderma gangrenosa. This is what it looks like. Okay. And then you can also have malignancies. If you have wounds in strange locations, you just start thinking atypical. If you're in my office, I have a 3-volume book about atypical wounds, and they're this big. There's a lot more stuff, but that's not entry-level stuff. Okay? So again, it's not always a duck. So don't make the easy diagnosis of that. The rest of it, for managing, is easy. Educate, reposition, offload, treat what you see. Just like every other wound. The hard part is the staging. Okay? So, I left this stuff in here for you, so in case you see these grayed out slides you do not want to know for the exam, you do want to keep for clinical reference because this is the old staging system and what the definitions used to be. I didn't want to delete them because you're still going to probably encounter them. So I left all of these in here. Oh, and this is blanchable versus non-blanchable. Okay. So I left in all the old things in here for you to see what pictures are. And all of these down here were pictures of my patients that I took that had these things. So you can see some of the things in vivo, what it looks like. Like this. That's unstageable. I have no idea how deep it goes. I have no idea. Okay? And this is, well, the Wound Care Educational Institute, of course, they had to pick a food as their, as their logo. And so they have always apple shirts and stuff. And they do a bunch of analogies with apples. So this is the old way of doing it. But I liked it because, you know, they looked at the apple. Like, it was a really good analogy. What stage is it? What stage is it? Heal, blister, fluid filled.
Unstageable.
2. What stage is it? Heal, blister. 2. Yeah, but what happened to the fluid? Have you ever seen that before?
Drain.
So a lot of times blisters on the heels will start to heal underneath it because of all the cool things that are in here. And so if they're fluid, we typically leave them alone. If they're thick, we usually pop them. But the fluid ones will get reabsorbed. So this is what the body does on its own to heal it. I was ultrasounding this man's heel. And after 2 days, the blister was gone and it was healing. 2 days later, this whole thing healed off and he had healed skin. It was pretty cool. So if you've never seen this, that's a good sign because it's going away.
You said that was stage 2?
Yeah. Blisters with the roof on, top of the skin is a stage 2 if it's over a bony prominence. Blisters as a whole can be a whole bunch of weird stuff. So you have to be looking to see where they're occurring. Blisters on the spine along the dermatome can be shingles. And so a lot of the cases I used to get called in for blisters, I would always go on a glove and be like, they're not on contact. I'm like, I'm not taking a chance. I don't like blister phone calls. I've seen too many bad stuff. Okay? This is stage 3, because that one's hard, and that's a stage 4. You can see the eventual death. That's unstageable. So, I gave you, and the rest of the slides here are the typical, there is no, like you had like that, like when we talked about arterial versus venous. Where do they appear? What do they look like? There's no norm for pressure injuries. So these give you some characteristics of what you could see, not everything that's possible. So I put them all in here. Okay? And then I showed you what some of the other stuff looks like. Pain, other comorbidities, all this stuff I think is really self-explanatory. They have a lot of pain, you gotta control the pain, right? Perfusion, if they don't have good perfusion, we have to make perfusion bags. Yes?
The pictures, the bottom pictures that you were showing, I just missed,
That was a stage 3.
this is 3, let's say 1 and 4.
Yep. Okay, prognosis, to help guide prognosis, the research says the following. If you have a pressure injury stage 1, see there's no old school, I didn't change it. It can resolve on its own within 1 to 3 weeks. Research says 2 within days to weeks, because that's as good as they've done through how many years we've had pressure injuries? Drives me crazy. Stage 3 and 4, there's a lot of research on between 8 to 13 weeks. So when you're looking at prognosis for wounds, there should be enough evidence nowadays that you can actually search the literature and pull prognosis out from the literature source. Yeah.
Wait, you said it less region on a stage 2, or why does that feel quicker?
What? Stage 2 may take days to weeks.
Does it feel faster than stage 1?
That's not what the article said. It said days to weeks. Good question. Okay. What can you do about it? There's all kinds of ulcer assessment instruments to help you document how wounds are progressing with this. Here's the names. Okay? So this is when I have a pressure injury, and now how's it doing? I want to use one of these scales, not one of the risk assessment scales. The most commonly one you're going to run into is this one, the push scale. And this gives you step-by-step directions. You measure length times width, and then that comes out to math. You see which one it is, and then you give the number here. Exudate, I have no exudate, it's gonna get a 0. Tissue type, I've got granulation tissue, it's gonna get a 2. You follow me? Okay, then you sum it up, and then you graph it out. It's a nice way to quantify staling, progressing, worsening, all of those things can happen. It's just one piece of the tool, okay? And then these are the other things. What should you do to treat? In the rest of this lecture, I highlighted out the major things. However, the clinical practice guideline book is the gold standard. "75 pages. Compiled from the NPUAP, EUAP. It gives you their rating of evidence. In here, it tells you which one it was. So they'll say level 1, 2, 3 to 5 in strengths of evidence A to C, and then they give you different recommendations of strong positive, definitely do it, probably do it, maybe, maybe not, don't do it, thumbs up, thumbs down. Medium or thumbs up is good, thumbs down, bad. Okay? And then you can scope through the table of contents. It tells you the background, it tells you prevention, it tells you interventions, it tells you treatment. What should I clean it with? What should I debride it with? What should I do for dressing? What should I do for modalities? What should I do for surgery? What about all these special populations? And what's going to make things go really bad? Step by step by step with all the evidence in one document for you. It's free. It's posted on Blackboard for you, the whole thing. Okay, and we're not reading it. That's the end of the pressure injuries. Everything else you can read through on there. Okay, but I did want to not explain the staging system and the pathology because I think it's too hard. And I still have not figured out why that recorded lecture did not work. And I recorded it twice. So 4 hours I spent recording. And you guys still didn't hear it. I almost threw something. I was so mad. I was so mad. I'm like, you're kidding me. I don't have 4 hours to spare. So, note to self, I'm going to try to do like a short mini one slide and see if that saves next time. Before I do the whole thing twice and then have enough. Okay. Go walk, breathe, 5 minutes. We're going to talk about pediatrics. And that's my favorite lecture of this semester. And you'll understand why in a moment. Oh! Did you guys get this announcement?
No.
Yes. Okay. How is it presented to you?